involved in upper limb. Anything above T12 in theory you can do, but I would say about T10 to be safe. T11, 12, I'm not very keen because it's so it's close to the conus and you can get lumbar root problems. Unlike podotomy, where you really have to be ideally above C6 and definitely not above C4, with this you can go all the way up to C2 if needed. So I tend to use absolute alcohol because it's much easier to position the patient like that rather than that with phenol. And I don't have much experience with phenol in the subarachnoid space. So this is basically, it's a simple technique. All you need is a 22 gauge spinal needle. I like the feel of it. And you get CSF out. I had a patient who I probably have put the needle into the posterior spinal artery once. And then I modified the technique to go at a tangent and then didn't have any vascular problems after that. And the idea is that you can see the nerve roots are so thin, you want to go below that and you completely lyse it, and then you are literally getting it towards the DRG. So you get prolonged relief, and usually the procedure outlives the patient. So as I mentioned, since I had that vascular thing, I've changed the technique to go more tangential rather than going straight down, which is what all the old books were saying. You can again approach it more technically. You can approach it, particularly the mid-thoracic level, are most difficult. You can come to the same side or you come at an angle and get in there. And depending on how many levels you want to do, you adjust the depth. You can go up to 6 levels if you get required with a single emery pond, and that's the other beauty of it, rather than some people putting a needle at every single level. But you have to use a tilting table to get it floating up or down, and I prefer to do it in one direction rather than bidirectional. And again, as I said, after this, I've tried writing up, I've got the technique and everything written up, but I'm going back to the patients. They're all lost to follow-up, or they're involved in other clinical trials, particularly oncological clinical trials, and collecting data is next to impossible. Good thing about this, unlike radiofrequency technique, is that you can go through metal work, go near metal work, through pacemakers, implantable defibrillators. And then one of the questions that I was always asked is that, particularly with patients living longer and longer, do you see deemphysization pain? And the answer is no, because this patient survived this is my longest surviving patient for 16 years. She passed away last year, 2021, sorry. She had the metal work done after I did the procedure because she was not even considered fit for surgery, had a massive lymphoedematic arm. But she responded very well to treatment, cancer treatment. And my theory is that there are twofold. One, the motor fibers have got far more projections into the brain, so we're keeping that intact. Maybe that's one reason. Second is that we are preemptively treating most of these patients with neuropathic pain medications. So some of the central effects maybe have, I don't know, I mean, I would love to find out what exactly is happening, but as I said, I've done nearly 2,000 patients, cervical and thoracic, and I haven't seen the differentiation. And some of them, there are a lot of patients who live longer than 3 to 5 years, so they haven't come back. And some of them are lost to follow-up, but they usually do get back to us if there's a problem, because the palliative is very good at doing that. One of the things I was looking into is that can we do lumbosacral selective neurolysis? And this was a young girl, unfortunately, aggressive sarcoma, daughter of husband and wife, both were my colleagues, so that didn't make it any easier. And so the choice was, do we do a podotomy in this patient or do we put a pump in? And it was a quite easy decision because the girl said, she was adamant that she didn't want either of them. She was a very slim girl. So she already had a foot drop. So what we did was to do stimulation intrathecally on the S1 route and literally 2 drops of absolute alcohol in. She had already got a foot drop, so we hadn't anything to lose. And I wasn't expecting her to survive more than 6 months, but I'm glad I didn't do a podotomy, and I'm glad we didn't do a pump, because she did this thing, and she's finished college, and she's been postgraduate in accountancy. So I'm not going to talk about podotomy because Robert is going to talk about that. Again, the indications are predominantly unilateral pain and lateral surgery. Having said that, this is where I think podotomy has got a real role. when you got aggressive sarcomas and you want to do one definitive procedure, there isn't anything else to be prototomy for this. And I will leave it with Robert to talk about that. Other problematic patient groups is widespread metastatic disease or myeloma. Bone mets are significantly painful. One of my biggest bugbears is that orthopedic surgeons wait till the fracture happens before they do anything. And I think there is a case, if you think that there is a patient who is at risk of having a fracture, why don't you preemptively do it as an elective procedure? Still haven't been able to convince our orthopedic colleagues on that. It's mentioned earlier about vertebroplasty and kyphoplasty. Actually, from a pain relief perspective, no difference, but when you look at if you start measuring vertebral body height, obviously kyphoplasty has an advantage. And this one, again, Marshall is in the audience, is one of their seminal papers which I've got a lot of time for, because the conventional thinking was that it's about stabilization of micro fractures, but David and Marshall has demonstrated that it's more likely to be the neurolytic effect of the cement, amongst other things, that produces it, and I think that is the case. Again, there are a lot of controversies coming on with various studies with kyphoplasty and vertebroplasty, and we know that if you really look at the outcome measures, particularly when you know that it's vertebral body fractures in the elderly, with osteoporosis particularly, it kills more patients than a fracture neck or femur. But we don't refer these patients on time. Every outcome measures at 1 month was better than conventional management. And myeloma, again, it gives significant amounts of relief, but the problem we find is that for multiple levels of vertebral body fractures, we don't know how many levels you want to put cement in. The bookbinder study was really bad for vertebroplasty, and really some of the funding organizations were quoting that we stopped it, and we had to have responses to that. In cancer pain, previously we were using coablation to burn the tumor away and put cement in, and now we lost funding about it, and it's not being done in the UK anymore, where we can do radiofrequency with cooled radiofrequency technology, burn the tumor more specifically, and then put cement in. But then again, I think at the moment in the UK these things are not funded. One of the things I want to say is that single level vertebral body fractures and all, usually that once it's stabilized, or even after vertebroplasty, it's the posterior component that causes pain. So again, you revert back to common sense medicine. You get radicular symptoms, try an epidural. If you got posterior axial symptoms, try middle branch blocks, and then go and do your conventional RF. And in thoracic spine, of course, you need to do a schooled RF. But again, we have the skills, we have the kit, we know how to do it, but we need to think outside the box and do what is right. So again, this is again a patient who literally came to me with 425 micrograms of functional patch, and his pain, again, the question you asked about breakthrough pain. His pain at breast, well, he's on ridiculous amounts of opioids, but he was taking 120 milligrams of oxycodone up to 10 to 12 times a day, 24 hours, for breakthrough pain. Every time he rolls, he screams. And these are patients, why do you want to be on such amounts of opioids? There are interventional options you can do. And then there are myeloma patients. This is again, I put this in because it's just to show what is possible. This lady used to be a model in the 50s, and she was 76 when she first came to me. Didn't tolerate medications very well, didn't want to do, still very active social life. Again, did diagnostic block, initially in the lumbar spine, then I had to go into the sacrum as well. And all I did was conventional denervation. And these two procedures were about 2.5 years apart. I had to repeat the lumbar RF, but she survived for 9 years since I first saw her. So simple treatment options do work. Going briefly into visceral pain, and again, this is where again interventions do have a crucial role, and we need to get in there quite early to reduce the opioid burden and other drugs like ketamine and pentanoids. So one of the things which I've changed, and I'm trying to change in the practice, is that we all were taught about putting 10, 15, 20 mils on either side, on both sides, local anesthetic or 50% lidocaine and absolute alcohol, so 50% alcohol it becomes. And that caused a lot of problems, severe hypertension, diarrhea, especially when you do bilateral. Of reduced volumes. That's 3 mils, that's 5 mils. This, and again, less than 10 to 15% of patients I do bilateral. Most of them only need unilateral blocks, and you can capture the branches coming from the other side if needed. And that reduces the incidence of diarrhea and definitely the autonomic disturbances they get. Again, conventional CT guided, they were putting again about 15, 20 mils in there. We put about 3 mils. You can go through liver, you can go through stomach, you can go through transverse column, nothing happens. We worry about it, and the reason, put it into perspective, when you put a 22 gauge cheaper needle through that, everybody makes a fuss. Nobody makes a fuss when you put a biliary stent thicker than my finger. So, use context. And even with the interventional radiologist, when I first started doing this, I said that you put it into the liver, you bring it down, the rest I will take over. You work collaboratively. And then once they realize that all these people who are objecting to this, it's silly. When you show them this picture, common sense wins. You can do thoracoscopically under direct vision. Don't do that much at the moment because I simply do it using fluoroscopy. It's much more efficient. Just want to get a theater slot is there, and also the comorbidities following the procedure are quite high, and a lot of them don't want to go under the anesthetic. Again, I use a combination of radiofrequency and a neurolytic block. For cancer, for non-cancer, it is predominantly radiofrequency alone. Techniques are still the same. Again, in cancer, as I mentioned, you combine the radiofrequency technique with a little bit of neurolytic agent, and I use absolute alcohol in the recruitment space. Then you can do it with endoscopic ultrasound. And again, gastroenterologists, my advice to them is that pain is a presenting feature for pancreatic cancer or stomach cancer, and you're doing a biopsy. Please go through the lesser curvature and do a block and come out. And that will enable the patient to have better quality of life while they're going through their treatment, which usually are not going to be successful. You can also do anterior ultrasound guided. We do it as a bedside procedure in patients in hospices who can't travel in. Again, it's a relatively simple technique because most of these patients are quite emaciated. Unless they have got a situs, then it becomes a little bit more challenging. Superior plexus blocks, very effective in pelvic malignancies, but again, I would say that if you are in a practical way, if you're going to do it as a neurolytic block, do it with a combined with a caudal, single caudal epidural, and see whether it's a combined somatic and vessel component, and do that. You can go through the disc, or you can even go through the thecal sac, but if you have tumor sitting in the front, that depends on the anatomical presentation. Ganglion-imbark blocks, again, it's a volume thing. If you're using larger volumes, it will cover other pelvic malignancy issues. But if you do it specifically at the lower coccygeal or sacrococcygeal junction, it covers the pain around the anorectal region, and that's that sort of tennis point pain. It can help at times, but it's a hit and miss as far as I'm concerned. Again, intrathecal drug delivery systems, very quickly, one of the things, it doesn't work in everybody. That's the first thing. It's ineffective in at least in a third of patients. It's not very good in neuropathic pain, incident pain, and patients who've got cutaneous ulcers. And then a lot of these patients are on high-dose opioids that you've got to be very careful that switching over to an opioid-based intrathecal pump is not going to make any difference. So one of the problems was that when you do intrathecal trial and then you get really good results, you put a pump in and you're not getting it, we looked at the reasons for it. When you did a study about methylene blue and see where it is spreading, you can see that it's only spreading in the posterior aspect, about 2 to 3 levels maximum. That's the lateral, and nothing in the anterior aspect. And when you look at the infusion, and about 20 microgram per liter per hour, 20 microliter per hour, covers only a couple of dermatomes. Whereas when you do an injection, this is 1 mil over 5 minutes, and I can guarantee you most of us, when we do the trial, we don't even inject in about 30 seconds. That's how we used to do trials. And this is 1 mil over infusion of 5 minutes. Look at the spread. And this is the problem, that what you do in a trial, you do not get it in when you do a pump, but you end up escalating the dose. So the catheter tip has to be bang in the middle of where you need it. And that's again another challenge. Briefly about capsaicin patches, it completely changed the paradigm in treating chemotherapy-induced neuropathy, particularly patients who are undergoing the treatment, and they were highly motivated to have the treatment dose. So if you got grade 2 neuropathy or more, they either stop the chemotherapy or reduce the dose, neither of which was acceptable to the patient, and of course the oncologist wanted to continue with the trial. So we proactively were treating them with capsaicin patches, and we could get them through the chemotherapy. And obviously, of course, we do have cases that come with post-chemotherapy-induced neuropathy as well. The idea is to effectively give the epidermal nerve fibers a haircut, which is that you are reducing the epidermal nerve fiber density, it goes back, and a lot of the chemotherapy-induced neuropathy patients, they may have some persistent numbness, but if you can get them mobilizing, that makes a big difference. So this is where we use it, and it's a bit labor intensive, and it's purely done by our nurses, so that it works out very well from a financial perspective. But also, we give it for other peripheral neuropathy cases and radiation-induced allodynia, we can use that very usefully. Lastly, about neuromodulation, a lot of the neural pathways, when they are disrupted, blocks are not going to work. There is anatomical disruption, there is physiological disruption. And this is where neuromodulation may have a role, but we were limited because of MRI compatibility. Oncologists did not want them because they wanted frequent MRIs, particularly if they are a clinical trial, monthly MRIs, some of the cases. Radiologists did not want it, artifacts, and again, compatibility was. When these two arguments come, the patient is not interested. But now we have got MRI compatible products, and we can stimulate anything. We're getting there in that aspect. And before that, because of the MRI compatibility, we were just using percutaneous peripheral stimulations. Now, even peripheral neuromodulation, we got sessions this afternoon. The technology has changed immensely. But a lot of the head and neck cancers who did not respond very well, did really well with simple stimulations and could repeat it as an outpatient procedure. Also, we've been doing some posterior tibial nerve stimulation for pelvic pain related to pelvic malignancies. Again, if you look at the articles, we still think that opioids are the most effective agent in a population base, and we don't have much support for stimulation. Lastly, always remember why interventions fail, because that's the usual thing, and this is what gives interventions a bad name. This applies for cancer pain also. Wrong diagnosis, wrong target, and not hitting the target. You are not going to get a positive finding. If you hit multiple targets or you flood the whole area, the patient says, my pain relief was brilliant, it lasted for 4 weeks, what are you going to do next? You don't have an answer. Again, patient selection is key, because if you've got incomplete pathways, you are not going to have a block. Then you have other factors that compounding. And cancer patients, once you take care of the physical pain, you're not going to stop them from fearing about dying and what's going to happen to the family, etc., etc. So it's very important that you have supportive systems in place for that. I have to invite you for the British Pain Society annual scientific meeting in Glasgow in May. So please, those of you can come, we would love to see you there. And I would like to thank you.
Thank you very much, Arun, Bhascar. It was a very nice presentation, and it was just like always, you are really giving us things to do and also to improve our daily practice. So it is a little bit over time, so I think we have time for 2 questions, and Dr. Bhascar will be around.
I can take it during lunchtime if you want to do the presentation.
Just one quick question, Dr. Arun. About the beta cell non-Hodgkin's lymphoma, whether the pain intensity is very less or there is no pain for such kind of cases and there is no place of opioid for such patients?
I think the problem, see, certain cancers we know cause a lot of pain for a variety of reasons. Usually it is tumor infiltration of plexuses or visceral tissue being obstructed. Okay?
One more question.
Thank you, Dr. Bhascar. I have just one question. At what stage the interventionist should take up? I mean,
Sorry, can I just come down? Just.
Like, as per the WHO letter, we have to start with first non-steroidal, then weak opioids, then strong opioids. So what's the actual place of these interventions? At what
Question to you, do you believe in the WHO lab?
No, believe or not, but I'm just asking you, at what stage we should take our, the interventions that we should take our patient? Okay,
No,
let me,
this is what I'm trying to say. We should not follow a linear model. We need to do what is fit for purpose. That's why I used the example. If you get acute appendicitis, you can manage it medically, but would you do it?
no.
Thank you. Same thing. It depends on what it is, and the best indications for interventions at an early stage is if you're managing with medications and you don't have any side effects, have no issues. But most of these patients, you know, say for example, breast reflexes involvement. You sneeze in that room, they will scream. Pain at breast when they are staying still with their arm like this, no pain. You do that or you try to clean their armpit, they'll scream the place down. So you got to be, if you can manage it without intervention, I have no issues. But if you are requiring 6 to 8 doses of rescue analgesia on top of the background medication, that's a problem. So I would look at, if you're managing with 2 or 3 doses, I don't have a problem. If you reach 4 doses of rescue analgesia, is there a role for intervention? If you are on more than 100 milligrams of morphine equivalent a day, look for whether it's an intervention option. And I'm very clear in my mind. Not every pain can be managed with interventions also. What we are trying to do is, what is the best option for the patient in the long term? Now, a lot of the issues, why opioid becomes that the exit strategy in that model is a good death. The patient survives, you have a problem. You now have a patient on long-term opioids and palliative care doesn't want to do anything with them. How would you manage them? I would rather prevent that problem.